in the postprandial state in a non-diabetic individual and glucose metabolism in the fasting state in a non-diabetic or healthy individual. And then we can compare the abnormalities in carbohydrate and lipid metabolism in diabetes mellitus. So in the postprandial state, when the blood glucose concentration rises, glucose stimulates release of insulin from the pancreatic beta cells. Broadly, insulin has two main actions. Firstly, it facilitates the uptake of glucose, fatty acids and amino acids and facilitates its conversion into various storage forms in various tissues such as skeletal muscle and adipose tissue. And secondly, insulin lowers the blood glucose level by reducing the breakdown of glycogen to glucose by the process of glycogenolysis, and also it inhibits the conversion of amino acids to glucose and the release of glucose into the circulation. So by inhibiting glycogenolysis and gluconeogenesis, it reduces the blood glucose level and helps to maintain the blood glucose level. So let us see what are the actions of insulin on glucose, fatty acid and protein metabolism. Glucose transporters, specifically the GLUT4 transporters, are predominantly expressed in the skeletal muscle and adipose tissue and is dependent on insulin. So insulin binding and action facilitates the entry of glucose through the GLUT4 transporters into the skeletal muscle. The glucose in the skeletal muscle is either oxidized to generate ATP or excess of glucose is stored in the form of glycogen, which can be utilized later. Also, insulin facilitates the uptake of amino acids into the skeletal muscle, and these amino acids are converted into protein and is stored in the muscle. In the adipose tissue, insulin facilitates the uptake of glucose through the GLUT4 transporters, and the glucose in the adipose tissue is converted to free fatty acids, and excessive free fatty acids is stored as triglycerides in the adipose tissue. So now coming to the liver, the glucose transporters that are expressed in the liver are GLUT2, and GLUT2 transporters are independent of insulin action. So insulin does not facilitate or transport glucose into the liver. So glucose is freely transported into the liver, but insulin facilitates the conversion of glucose to glycogen by the process of glycogenesis and by stimulating the enzyme glycogen synthase. Insulin also facilitates the conversion of glucose to free fatty acids, and these free fatty acids are converted to triglycerides. The triglycerides are transported by lipoproteins or VLDL lipoproteins, which carry large amount of triglycerides, and these lipoproteins express apoprotein C2, which is expressed on the surface of the lipoprotein. So the triglycerides are carried by VLDL to the muscle and adipose tissue for utilization. So lipoprotein lipases, by acting through apoprotein C2, causes release of free fatty acids to be utilized by the muscle and adipose tissue. So insulin stimulates the expression of apoprotein C2 expressed on the surface of VLDL protein, and lipoprotein lipases on the endothelium causes release of free fatty acids from the triglycerides, and these fatty acids are utilized by the muscle and adipose tissue as alternative fuel. So in this way, insulin facilitates the uptake of glucose, free fatty acids and amino acids, and also facilitates the conversion to glycogen, which is stored in the liver, which is stored in the skeletal muscle, and the triglycerides, which are stored in the adipose tissue. Now let us see what are the effects on glucose metabolism in the fasting state in a healthy individual. In the fasting state, as the blood glucose concentration drops towards normal, several processes are activated to maintain a minimum blood glucose concentration. Because a blood concentration of 40 to 70 mg per deciliter is required for the central nervous system to function. So to provide glucose concentration to the brain, processes are activated to maintain blood glucose concentration in the range of 40 to 70 mg per deciliter. So firstly, insulin secretion is inhibited, and since insulin secretion is inhibited, there is diminished uptake of glucose by the muscle, adipose tissue, and this helps to conserve the blood glucose concentration in the circulation and helps to maintain the normal blood glucose level. Also, to maintain normal blood glucose level, several counter-regulatory hormones such as glucagon, epinephrine, growth hormone and cortisol are secreted, and these help to raise the blood glucose level to the normal and maintain the normal blood glucose level. In response to a decrease in blood glucose level, the glycogen which is stored in the liver gets converted to glucose and is released into the circulation. So there is stimulation of glycogenolysis by stimulating the enzyme glycogen phosphorylase, and glucose is released into the circulation. Also, amino acids are transported from the skeletal muscle to the liver, and amino acids are converted into glucose by the process of gluconeogenesis. So gluconeogenesis leads to the formation of glucose from amino acids, and glucose is released into the circulation, and this helps in maintaining the blood glucose level. So to sum up, in response to a decrease in the blood glucose level, insulin secretion is inhibited, but the counter-regulatory hormones such as glucagon, cortisol, growth hormones are released, and this helps to raise the blood glucose level. Also, glycogenolysis and gluconeogenesis are stimulated, and this causes release of glucose into the circulation and helps to maintain the minimum blood glucose concentration. Now, when glucose levels are low in the circulation, body fat and proteins undergo breakdown. So, lipids undergo lipolysis and proteins undergo proteolysis, releasing amino acids into the circulation. So, triglycerides in the adipose tissue are broken down into free fatty acids, and these fatty acids are utilized as alternative fuel for the skeletal muscle and adipose tissue. Now let's move on to the metabolic effects in diabetes mellitus. Now diabetes mellitus occurs due to abnormalities in carbohydrate and lipid metabolism due to impaired insulin secretion or insulin action or both. It is clinically characterized by fasting hyperglycemia and elevated glycosylated hemoglobin. So initially there is postprandial hyperglycemia, but as the insulin secretion becomes more and more compromised, there is fasting hyperglycemia and there is an elevation in glycosylated hemoglobin. Now, as the glucose concentration crosses the renal threshold, glucose appears in urine, and this is known as glucosuria due to the appearance of glucose in urine. Since there is loss of glucose, there is loss of calories, the body fat and proteins are broken down by the process of lipolysis, releasing free fatty acids, and proteolysis, causing release of amino acids to be utilized as fuel for action. In the liver, there is release of free fatty acids, and in the adipose tissue, the triglycerides are broken down to release free fatty acids into the circulation. So, in presence of insulin deficiency or in absolute lack of insulin, there is excessive mobilization of free fatty acids into the liver, and these free fatty acids are converted into ketone bodies. Due to excessive formation of ketone bodies, there is ketonemia. The excess of ketone bodies are secreted in urine, and this is known as ketonuria. There is also ketoacidosis because of excretion of ketone bodies in urine. So this is about abnormalities in carbohydrate and lipid metabolism, which occurs because of absolute or relative lack of insulin due to destruction of the pancreatic beta cells and leading to abnormalities. In the long term, these metabolic abnormalities can lead to complications such as cardiovascular disease, nephropathy, neuropathy, and increased morbidity and mortality in patients with diabetes.